Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
All right, what's up, guys? It's Erin Faules, one of the Wild Health docs. I have Dr. Mark Goodman here with me today. You guys have probably heard him on the podcast before. He does consults for Wild Health. He's just an awesome human being. He lives in Bend, Oregon with his 2 kiddos and his wife, and he does non-operative sports medicine and is double board certified also as an ER doctor. So essentially, helping athletes and regular people, I'm guessing, just maintain their joint health and stay out of the operating room as long as possible and do all the things they love to do, is my guess. So I'd love to hear you expand a little bit more on that and correct me where I'm wrong, Mark. And then we'll dive into some of the cool stuff that Mark does. Specifically, like how do you get beyond what kind of the old school way, in my opinion, of orthopedics kind of is. Like, do you operate? Do you do steroid injections? Do you do PT? Like, there's a lot more to it. And how do we support joint health in a new way? And he can teach us all, myself included, today. So, what did I miss, Mark?
Yeah.
How else would you introduce yourself?
Yeah, thanks for having me, Aaron. I really appreciate you having me on. So, I have a pretty cool job that no one really knows exactly what I do because I think this field of primary care sports medicine, non-surgical sports medicine, is relatively new, and there's a ton of us out there that have done fellowship training in non-operative orthopedics and sports, and the practice spectrum is kind of all over the place. And so, our role is really to kind of fill the void between going to your family doctor, physical therapist, and an orthopedic surgeon who is more on kind of the surgical procedural heavy side. And if you look at kind of data of the random person who shows up, who walks in with an orthopedic injury, 90% of those people don't need surgery. So there's a lot that we can do between, someone who has a knee or a shoulder who hurts and then sending them to see a surgeon. So that's the void that we're trying to fill. And so I think it's really neat because I think, myself and a lot of us in this space have a pretty generalist background. So, training in emergency medicine and being able to, work with people from the medical side of things also adds a layer of value, I think, to these patients. We can recognize some of these things that maybe our surgical colleagues aren't as focused on or don't have the background in. And then, on top of that, being, part of Wild Health in the past and helping with some of this metabolic and the lifestyle intervention side of things is definitely an emerging role in the sports medicine world. And just the recognition of, so how does metabolic health play into bone, joint, muscle disorders? I think we've really under recognized that in the past, and that's changing at this point, which is pretty cool to see. So, my practice is I see athletes of all ages. I spend a lot of my time seeing aging athletes because I am an aging athlete. So I feel like as you get older and we still kind of are pushing our bodies to do all these things and want to be doing things, start to not work as well. We get, aches and pains and don't recover quite as quickly. And that's kind of the sweet spot where I like to work is people who are, kind of still pushing their limits as they age. And how do we do that and age gracefully and do that in a way where we're protecting our bones and joints over time?
Yeah, for sure. I mean, it's not been that long ago. I mean, even when I went to med school, I feel like there was still this idea that like the cartilage just broke down as we aged, and especially when you add more weight to the body, that's what causes it. And we now know there's so many reasons why, more fat tissue, can increase arthritis and increase like degenerative joint changes. But like it's so much more than that. Cause like why would we have like big muscular, super heavy football players with really like healthy joints, that are super heavy, right? And some young, really thin people with really, really painful joints, right? Like it's not
Yeah.
it doesn't always like fit that paradigm, but I feel like that's what I was taught not that long ago, like in broad strokes. I mean, I was taught a little more detail than that, but we know now there's like a living, breathing environment there. I mean, not actually breathing, but like a living
Yeah, there's
environment in the joint, right? That's affected by a lot of things in the body.
Yeah, but I think we've oversimplified, I mean, kinda a little bit similar to type 2 diabetes or diabetes, it's like we've oversimplified this common outcome of degenerative joint disease to be like, "Oh, that's just, wear and tear on the joint." It's like, well, there's a
Right.
lot more
Is
to it than
See, you
that,
say it so much better than
right?
me.
So that's the common pathway, people end up with wear and tear in the joint, but how did they get there and what's playing into it? And there's multiple different pathways that play into that. And one of them's inflammation. So, systemic inflammation plays a big role in the metabolic environment of the joint itself, as well as, chronic micro injury and biomechanics play a role. There's a role for, cartilage breakdown is certainly part of that, but is it the primary thing or what got you there? And, it's kind of interesting. You look at some studies about metabolic health in patients who develop arthritis. And if you control for body weight, people who have poor metabolic health still go on to have a higher risk of bone and joint disease. So, obesity and just mechanical loading of the joint, like that's a real thing, right? If you're very overweight and you're putting a ton of stress across your knees, your hips, your joints, that does play a role, but it's probably not the only thing. And so I think we've oversimplified
Yeah.
things in a way that probably isn't fair to the actual complexity of what we're dealing with these metabolic processes.
Yeah, cool. Well, I'm excited to dive into a little bit more about systemically what we can do to help people because that's, selfishly what I have more control over as a provider, as a precision medicine provider. But also, one thing we're going to talk about today is something called orthobiologics or kind of a different way to intervene when people are having more, specific joint complaints and issues. So give me, if you don't mind, a quick and dirty of how you would describe what orthobiologics are for people who are new to this, and myself included.
Sure. So, I think, and this is kind of parallels to what we were talking before. So, in the past, we've always kind of thought about the traditional model of treating these conditions, and the tools we mostly had have been steroids. So, the treatment for inflammation is to just suppress inflammation. And more, I think we're learning that there's a component of inflammation that can actually be helpful over time. And there's a component that's definitely detrimental to the joint. So this systemic kind of low grade uncontrolled inflammation is something that leads to more breakdown and more pain. At the same time, having some small amounts of inflammation, like, if you go out and exercise and you get sore, like you get some inflammation, and that's beneficial to be stronger and to rebuild muscle and cartilage and, to synthesize a beneficial response to those tissues. And so more and more, I think the paradigm is shifting in orthopedics, especially what I do in kind of regenerative orthopedics to say, all right, you know, is steroid really the only way to treat these bone and joint conditions? And so the conversation I typically have with patients, I say, okay, well, there's, you've got knee arthritis. We've got a couple options on how to treat this. The traditional thing is we can do, physical therapy. We can do oral medications, ibuprofen, Tylenol, anti-inflammatories. And those all definitely have a role, and I encourage people to try those. And then once we get into the role of intervention, so on the injection front, there's really kind of three pathways we can take. The first would be, steroid injections. And so the benefit there is we're suppressing inflammation in the joint. And there's certainly a role for that. So if someone comes in and their knee is, swollen and painful and it's acutely inflamed and it hurts to move, and they're going on a trip or running a marathon or something, and the next week or two, like, steroids are the right choice there because we got to get that joint calmed down. But there's a lot of people that come in and they've just got a painful kind of stiff joint. It's not acutely inflamed, but it's been something that's bugging them for years and years. And in that case, maybe the problem isn't inflammation necessarily, but maybe it's this cartilage that has some disordered healing. Or more and more, we're thinking, okay, what else is going on in that joint beyond the cartilage? Because we know the cartilage doesn't necessarily have pain fibers in it. So the subchondral bone underneath the cartilage tends to get overloaded when you have cartilage defects. And so it changes the mechanical forces through the bone and through the ligaments, that, in the case of the knee, that support the knee. So you get instability. And then you get what's called these subchondral lesions in the bone. So if you look at an MRI, you can see these kind of bright areas or bone bruises. And those can be a pretty significant pain generator when you correlate that with where someone hurts. And so a lot of times the pain isn't necessarily the cartilage loss, but it's things that are secondary to that and surrounding it. And so, kind of going back to your question on orthobiologics, so then what can we do to actually create a healing response in there? And that's a couple things. So we have a couple tools in an expanding kind of menu of things to choose from on the orthobiologic front. But the general idea is we take your body's own cells and then we somehow synthesize those or compress those in a way we can inject it back into the joint to create healing, or into tendons or into the areas surrounding the bone. And so that comes in a couple different kind of flavors. The main ones are PRP, so platelet-rich plasma, where we take your blood, spin down your blood in a centrifuge. We take the platelets out of the blood and then inject that back into the joint or tendon or around the area we're interested in. Bone marrow, so where we take cells from your bone marrow. So typically that's from iliac crest harvest. And we take those cells, we spin that down in a centrifuge and concentrate it, inject it back in. Or in adipose tissue, so taking fat cells and then taking those and injecting them back into the joint. And each have their kind of roles and their ups and downs. In general, PRP is probably what I do the most of because we have the most data there to support it. And it's pretty quick and easy to do. Bone marrow and adipose have the benefit of carrying MSC, so mesenchymal signaling cells. We used to call them mesenchymal stem cells. We take more and more. That's kind of like more of a signaling cell that goes into the joint or into the tendon and then can signal other cells to go into that area to migrate and create healing. And so I think there's different roles for each of those, but that's where I think orthopedics is really heading as far as the regenerative treatments. And the data on that, is pretty good as far as getting longer term reductions in pain and improvements in function when we compare that to just steroid. And so that's what's really kind of got me excited in this space, going forward and what I'm doing more and more of.
Nice. And you're doing all of those types of injections in your group now.
Yeah, so we do PRP, bone marrow, and adipose. Um,
Cool.
yeah, the world at orthobiologics, biologic treatments, and these kind of stem cell treatments is the Wild West right now, right? So,
Yeah, sure.
from an FDA perspective, those are what we are allowed to do. So, we take that from the same patient. They're minimally manipulated. They check the boxes for being FDA signed off on and approved, even though we're using them in a technically off-label way for orthopedic conditions. They're FDA tolerated. But there are a lot of other things kind of out there that are sold as stem cell treatments you have to kind of be careful of.
Sure. Yeah, I imagine there's a big black box there you're opening a big box when people say stem cell therapy can mean a lot of different things. I know historically I've had patients that have like gone to other countries and done systemic stem cell therapies and things like this. And my thought with those scenarios is always like, how is the rest of the system going? Because you can like switch out like, I think of it as a metaphor for, like, you can switch out, like, a clean tank, but if you have, like, dirty water flowing in, like, it's kind of a moot point, and you're gonna kinda be back to where you started, at some point. Like, you really need to support the system if you're gonna do an overall healing approach like that, whether or not it's gonna work. I'm not even talking about the whether or not that's a good idea to do those therapies, but just the mindset that it's a quick fix, versus, supporting the overall system in the setting of doing a treatment like that. Is that similar for joint care? Like, if you do one of these orthobiologic treatments, but they're still in poor metabolic health or this or that or the other, like, is it really going to be tougher to see the healing that you want to see because it's just a part
Yeah.
of that overall ecosystem?
Yeah, absolutely. I mean, I think thinking about the joint as kind of a whole system is a big part of that. And like you were saying, putting the PRP or MSCs into a joint that's acutely inflamed and angry, or into a metabolic environment where those cells can't survive, but your outcomes just aren't going to be as good. So,
Mhm.
you can't really heal a joint if you have this big pro-inflammatory metabolic storm going on. And so
Mhm.
I think patient selection is a big part of that. So, knowing what the right treatment is for the patient at that time, and that can change over time. And then, you know, typically when I'm counseling patients on these biologic treatments, I'm telling them this is a long term or a long road to get you better. So we're really looking at 2 to 3 months to see positive
Mm.
impact. Where, the
Good to
steroid
know.
injection, I'll tell people like, okay, the steroid is like a light switch. Like it's going to turn on, it's going to turn off. You're going to feel better for a couple months. It's going to probably go away after that. But the biologics are typically more kind of like the dimmer. So you're like slowly turning things up over time with the goal though that it improves pain and function and then changes that actual metabolic environment in the joint for a longer period of time. And yeah, pretty interesting kind of data coming out, especially in the knee OA world. Actually being able to avoid knee replacement surgeries with these biologics, and I think there's more work to be done there. But that's kind of where things are coming. And we know that steroid, probably safe in small doses and everything, and has kind of a dose-dependent relationship, and it's probably not good
Yeah.
for you from a, an overall metabolic health standpoint, from a bone density standpoint, especially as you get into perimenopausal, menopausal women who are worried about their bone density, and it's
Yeah, so what
toxic
Mark's talking
cartilage
about, it's gonna
influence
raise your
too.
blood sugar, it's gonna reduce bone density, make you more likely to have fractures or breaks in your bone long term, like, especially people that get these recurrently, like, every few months for years. This can have a cumulative effect and be kind of a poor decision long term for someone, just for people who don't know that language as much.
Yeah, yeah, thanks.
Cool. So I have a question. You mentioned cartilage healing and regeneration as an indication for these orthobiologics. And forgive me if this is an ignorant question, but what about the people? I feel like this is just such a common clinical scenario, like the people that have, not an acute, like full tear or rupture in one of their major, like ligaments or what have you, but, like, say there's, like, a micro tears or a small tear in the meniscus, in the labrum, and, like, these super common injuries that we see in young active people or just everyday people,
Okay.
that are kinda causing this, like, nagging joint pain over months, and then they finally get an MRI and they're, like, have, like, a partial tear or something, and they may not even recall a specific injury, or they may. Like, for those types of scenarios, and you may not even be able to lump them all together. So again, forgive my ignorance in this field. But for those types of scenarios, when you can pinpoint an area of damage, are the orthobiologics still helpful? Or do they have utility in those scenarios, or does that still land more in the like surgical interventional world?
Yeah, great question. So, and the answer is it really depends, right? So
Yeah, sure.
it's complicated. When let's like take meniscus tears for a second, because it's such a common thing. And so,
Yeah.
an acute meniscus tear in a younger, healthy person. So if you're, 30s, 40s, you plant your knee, you twist, and you get this pop, you get pain, swelling, and you're having catching in your knee. And I get an MRI, it shows that you've got a meniscus flap. Well, that's not something that I can get better with biologic treatments, and I really
Hmm.
think the right choice at that point is to have you talk with a surgeon about what arthroscopy looks like, because I think there's a good chance that they can make you better. And they can
Yeah.
also avoid maybe further damage to your joint if we kinda mess around with biologics and some of these things that aren't gonna help, we're potentially delaying just a surgical intervention that could be more definitive. So, I work really closely with orthopedic surgeons in my community, and I definitely respect those guys' opinions, and,
Yeah.
they are also, I think they're looking for the right patient selection, and good surgeons aren't in a hurry to operate, but when they need to, they've got the skills to do it. So that'd be something I think would be a good indication for surgery. Whereas I think older patient that has some underlying knee arthritis, that has a degenerative meniscus tear, which has certain characteristics that we can see on MRI, and more kind of just nagging joint line pain, well, that person could be a good candidate for one of these biologic treatments. And there's a couple studies showing these degenerative meniscus tears, when we actually go in and inject with ultrasound into the meniscus and into the joint, can do pretty well with PRP or biologics. And so that's a discussion I'll have with someone at that point after kind of reviewing what they've tried so far and their exam and their MRI, and we can come up with a plan from there.
And I'm guessing there's a big gray area with those patients in the middle where they're like not obvious surgical candidates because it's not like a bad acute injury, but they really don't want to do surgery. I feel like this is something I hear so often by people. They're not like looking to get back onto their professional sports team or what
Yeah.
have you, and they're like, I don't know, I really don't want to do surgery. It's not like the surgeon said I didn't for sure have to do surgery. I just feel like I have these conversations pretty fairly regularly throughout my career. So I imagine there's like a big gray area of like it might help people.
Yeah.
Um
And
and it might not.
Yeah, I think part of that is just having realistic expectations and counseling patients, appropriately. And I try really hard to not be a salesman, but to be a doctor
Yeah.
for these treatments, right? And recommend what I've got evidence for, and try and tell people, realistically, like, I can't regrow you a new knee with these treatments. But what we can do is maybe help you, delay a knee replacement. Maybe we can help with the pain or help fix that degenerative meniscus tear. And so I think as long as you set the stage of what realistic expectations are and what we can accomplish, then we can explore some of these treatments in a way that the patients hopefully feel like they're getting good information on.
Cool. Are most of the people you're seeing a little bit older and have underlying degenerative changes or kind of that breakdown?
Yeah, it's totally across the board, and that's one of the things I actually really enjoy about my job is I'll see, 8-year-olds for fracture care from, a broken wrist when they fell off the monkey bars, and then my next patient will be 90, but someone who is a super active 90-year-old and still wants to be running, skiing, doing marathons, and everyone in between. Just as a function of where I live, we've got a large population of really active aging athletes. And so that tends to kind of be the major population I see. There's definitely some high level, Olympians and former Olympians around too. And that elite athlete
Oh, that's
population
rad.
is fun to take care of. At the same time that, the aging weekend warrior, there's a lot of us out there. So
Yeah.
I see a
Yeah,
lot of
yeah,
those.
yeah. Nice. And how about safety? Are you seeing a lot of side effects from these orthobiologics? Are they pretty safe?
Yeah.
I imagine it depends and it's case by case, but by and large.
Yeah, by and large, they're pretty safe. Anytime we do a procedure, there's certainly risk to that. So the biologics tend to be uh, pro-inflammatory initially. So
Mhm.
people tend to get kind of inflamed in their joint or tendon after these treatments. And so I
Makes
usually tell
sense.
people like, you're not going to like me for a week or two, and then I'll check in with most of my patients about the 2-week mark or so just to be sure they're doing better. But then there's really kind of a lag time. We're creating a new kind of stimulus to the joint or to the tendon to try and get a healing response. And so in order to do that, we have to give the cells time to migrate into that area and to get healing. So there's a lag between doing this procedure and actually seeing an effect, anywhere between, 4 to 8 to
Yeah.
10 weeks sometimes. And so that's the time to, really be optimizing physical therapy with a good PT, optimizing metabolic health with someone like you or the Wild Health team who's kind of working through metabolic optimization as well. And then a lot of it's kind of this waiting period to see how you feel. And, a lot of patients I'll see back like, yeah, I didn't think it was, this isn't working. It's not working. And then, oh, well, I was able to walk down my stairs. I didn't think about my knee. And so it's kind of a
Yeah.
slow process at that point.
Yeah, yeah.
Yeah.
Cool. It sounds not that dissimilar the way you describe it reminds me of kind of how wound care is handled
Yeah.
frequently of like you're kind of roughing up the tissue, to
Mhm.
create that nidus for the self-healing process to
Yeah.
begin again.
Yeah, and a lot of times I'll
So,
do, especially for some of these chronic tendinopathies and tendon injuries, what's called a tenotomy. So going and actually needling the tendon to get some bleeding and stimulate a new healing response in that area.
cool.
And then, yeah,
Nice.
I guess from a safety standpoint, there are, ways to do this well. And I think it's important if you're pursuing these treatments to find a provider who's done a lot of them, who is using ultrasound for guidance is really the standard of care to be sure we're delivering these treatments in the place where they're going to really kind of do the most good. And to find someone who's using, quality equipment. These kits
Yeah.
come in all kind of shapes and sizes. You want to make sure that, they're
For sure.
sterile precautions and minimizing any risk of a complication. So
Yeah,
those are things
especially
to
stem
look
cells
for.
are such a buzzword, I imagine,
Yeah, you have to
PRP
be very
maybe a little too
careful.
in this
Sure.
field. So you wanna vet someone well.
Yeah.
Cool. While we're on the topic of the Wild West in your field, let's talk about, things you're excited about that may be coming down the line that you're not necessarily doing now, but that you think are potentially like realistically on the frontier, or anything you're excited about in
Yeah.
terms of like upcoming interventions.
Sure. I'm gonna throw one thing in that we actually are doing now that I think has been
Yeah,
really cool is
rad, please.
shockwave therapy. So we
Okay.
just got the state of the art shockwave focused and radial shockwave machine about 8 months ago. And it's been like a total game changer for treating some of these chronic tendinopathies, especially like Achilles and plantar fascia. We're having some super good results with that, which I think isn't really Wild West. It's a very established treatment. It's been around for a long
Yeah.
time, but it's just not commonly used in the orthopedic world all that much for whatever reason. So that's kind of one of these non-surgical but interventional things that we can do. And
Super low risk, it sounds like.
really low risk, non-invasive.
Yeah.
Yeah, people can get back to the regular activities really quickly, and more I'm kind of pairing that with some of these biologic treatments. So almost like fertilizing the soil before we go in and plant the seeds of these, PRP or bone marrow, whatever we decide to do after that. So that's been something that's kind of new and cool to be learning about and how to integrate that to, what I'm already been doing. So, um,
Yeah, rad.
so that's been neat. And then, on the horizon, I really think this is such a cool field to be in right now because there's all sorts of neat stuff out there. Exosomes being one of them, which exosomes are on the market like 2018, 2019. We're actually doing some of those before the FDA cracked down on exosomes, which I think was a good thing actually, because I think the regulation and the safety um, just it wasn't in patients' best interest to keep going on the path that we were on. So those have been kind of pulled back into a research only setting, which I think is appropriate at this point until we really have more data on safety and efficacy for what we're giving and what the right indications are.
Sure.
And I mean, the idea behind exosomes is that we're taking kind of the chemical signals that you'd get with PRP or with some of these bone marrow or adipose treatments, and we're just taking the actual chemical signals themselves in these vesicles and able to inject those to create a similar response, but without the cell therapy part of it. So I think that's definitely on the horizon. mRNA or gene therapy is certainly, I think it's probably being done out there kind of under the radar. We are not doing that. Um, and that's definitely not FDA approved at this point. But I think that's also something that's coming down the pipeline here, hopefully pretty quickly, and being able to actually, induce mRNA to then synthesize proteins to change how the environment in the joint
Yeah.
functions. And I think that's going to be really,
You just go like
really cool in
directly
the
to the
future as
source
well.
there.
Yeah, exactly. So I think that's on the horizon as well. And then I think just more data around the biologic treatments already doing to really determine, who responds well to these, who doesn't. And that's something I think, and our clinic and myself, we're proud to be a part of this data biologics foundation. So we track all our patient data, our patient outcomes on these biologic treatments. So we're hopefully able to then contribute to the growing scientific literature around these, but also just look within our clinic and say, hey, when someone asks me, what's the chance that my knee is going to get better with this treatment? I can say, all right, I've done 200 of these, and out of those, 80% of people get this much improvement. And so I think that's going to be a really neat thing going forward as well.
So obviously you're personalizing these to an extent, looking at imaging in each specific case and just using your expertise. Do you think there's a world in the future that this is truly going to be biologically personalized for joints? I'm just
Yeah.
curious.
Oh, I certainly hope so. I mean, and you
Yeah.
guys are kind of on the cutting edge of that as far as the genetics and genomics piece of things, and then looking at epigenetic modifications, and kind of like we're talking about initially, the joint is so complex. There's all these common pathways, or all these different pathways that lead to the common outcome of things like arthritis and tendinopathy. And so, how can we then dial in to affect these different pathways in different areas and know in an individual patient which one's playing more of a role and tailor our therapies
Yeah.
appropriately? And I think that
Yeah.
is going to really be game changing when we can get there.
Cool. Cool. Nice. Sweet. Well, let's talk about some of those things within the system that affect this the most and maybe run through some common scenarios you see, if you don't mind. So, like,
Sure.
you mentioned inflammation and metabolic dysfunction. So inflammation, like our immune system acts, one of the reasons Mark said people feel worse before they feel better after these orthobiologics sometimes when the immune system acts on things, it doesn't, that part of healing is good for us, but it doesn't make us feel good. And when it's turned on for a long time chronically, it's not good for us any longer, right? It can just cause damage at that point. So a lot of things can cause systemic inflammation. We do a ton of that work at Wild Health. I do a ton of that work with my autoimmune patients and my standard patients, just general patients as well. Metabolic dysfunction that we've mentioned a few times, so things like insulin resistance, it's kind of what we're getting at there for the most part in this scenario. I think, so when you essentially don't process energy well from food or efficiently from food, but in the body, that can lead to a lot of downstream effects. And a common pattern with these individuals that we see is not enough muscle mass, too much fat mass, which then again worsens the inflammation component as well. So these things tend to go in tandem for people. And are there any other major body system dysfunctions that you see with your patients or any other big categories that you see that really, really affect this?
Yeah, I think you hit on some of the big ones, and some interesting stuff on actually measuring leptin levels in joints. So elevated leptin we see, in systemic inflammation and increased adiposity. Also, you can see that in joints as well, and that can be
Mm,
have a negative effect on cartilage
you
directly.
can just build fat tissue everywhere.
I know. So super interesting. I think the other piece would probably be hormonal health, and I think
Yeah.
more and more I'm seeing it, or maybe I'm just recognizing it more.
Yeah.
Perimenopausal women and menopausal women who have just this really kind of big uptick in bone and especially tendon and tendinopathy concerns as their hormones are changing in their perimenopausal state.
Mhm.
And I think in orthopedics in general, we haven't really been good at recognizing that and the role of hormone
Yeah.
health and the role it plays. And I mean, especially things like greater trochanteric pain syndrome. So it used to be called trochanteric bursitis, so pain on the side of your hip. It tends to be really common in perimenopausal women, and there's a big uptick there
I
as
think it's common
estrogen
in
levels go
postpartum as well
down.
when you get hormone
Yeah,
drops.
yeah. And so, more and more kind of recognizing that, and then, for me, I'm not an expert in hormonal health, but I think hopefully just by recognizing that's playing a role and getting them either tied in with their primary or someone who's comfortable discussing HRT and what the risks and benefits that are. And I've seen some pretty good outcomes, pairing HRT along with all the stuff that I'm doing from,
Makes sense.
a rehab program and from some of these biologic treatments, shockwave, along with
Yeah.
fixing the metabolic dysfunction that goes along with that. So trying to kind of treat the whole person as opposed to just being like, hey, your hip hurts and here's, some hip stuff what we're going to do for it.
Yeah, it makes sense. I think with perimenopause, it's in large part related to the other two large categories we've talked about with inflammation and insulin resistance because, estrogen is what drops significantly postmenopausally, right? Your ovaries are no longer producing estrogen. You produce a small amount via DHEA from your adrenals, but a lot of times in the perimenopause years, the adrenals get pretty beat too. So there's not a lot of that backup system and it's pretty minimal to begin with. So, when you lose estrogen, especially abruptly, estrogen has a really like anti-inflammatory effect. It also has an insulin sensitive effect and tends to buffer cortisol, which is the stress hormone. So when estrogen goes away, inflammation goes up, insulin goes up, and cortisol goes up. Cortisol going up then exacerbates both of those other two issues, right? Also, when you lose estrogen, you'll amongst other reasons, postmenopausally, it becomes more and more difficult to get new satellite cells in your muscles and put on new strength and gain muscle mass, both new straight cells as well as hypertrophy of the cells you have. Like, it becomes much more physiologically difficult. You have to have a much bigger nidus for strength, to be created. So women have to lift a lot heavier, essentially, to create muscle cells than they did when they were in their 20s and 30s. So oftentimes when women are perimenopause, when you think of what that feels like, women aren't sleeping well, their energy is low, they're struggling to lose weight the way they did, so they're probably not eating as much and trying to become more active. But oftentimes that's cardio, which sometimes can exacerbate all of these other issues. So I think it's such a complex scenario that women oftentimes, I think by and large, have not been well educated in. I'm talking to Stacey Sims upcoming soon on the show, and we're going to dive into this extensively because I think it's such a fascinating topic. But there's so many reasons systemically that women's joints would be hit harder around that time, and it can hit people, I think, like a ton of bricks. But I think it does come down to the big two buckets that we talked about, but just how hormones play into that. Lifestyle has a huge role there, but you're not wrong. I mean, HRT can be life changing for women, right? And
Yeah.
men in certain
Yeah.
scenarios, but
And I think I absolutely agree with you. Like optimizing the lifestyle side of things first before jumping to
yeah,
medication intervention it is always would be my preference. But then also, I think you mentioned briefly the sleep disruption part, and I think more and more like that disordered sleep and leading to increased kind of central sensitization of these pain pathways really ramps up all those pain signals as well, along with just the metabolic dysfunction that comes along with not sleeping well and insulin resistance we know that goes along with that too. And so, yeah, that's this complex thing to unwind, and shows up in all different sorts of body systems, but they're all kind of tied together in some way.
yeah, for sure. I think peripartum is another common scenario where you see a lot of these changes, big fluctuations in hormones, big drop in sleep typically, a big uptick in stress typically. I'm projecting a little bit because I have a 9-month-old who's the light of my life, but there's a lot of sleep disruption and changes, right? And then also women, when you're pregnant, you have this a little bit of immunosuppressed situation going on to protect the fetus, but then there's there's this uptick in inflammation that's normal once you have your baby, but then so you're in this pro-inflammatory state as your hormones are coming down. So you have all those other things we talked about perimenopausally to a smaller degree, but then you're also in this pro-inflammatory state comparatively. Um, at the same time that you're not sleeping well and et cetera,
And all these
right?
other things
So
on top,
it's
yeah,
and
the
and
perfect
joints, you
storm,
have this elastin hormone. So joints are, the body's actually changing
increased
physical
laxity.
structure. The
Yeah.
hips are changing structure. The joints are more elastic. So I think those two times in women's lives, I'd be curious if that's times you tend to see women more often because that's when I hear that their joints are hurting the most. I'll say that.
Yeah, definitely. I think that's been a big uptick in maybe I'm just recognizing it more, but that kind of mid-40s female athlete who all of a sudden they've been doing the same things for a long time. It seems to have been working, and now their usual stuff either isn't working or they're dealing with these nagging injuries that just don't seem to be getting better. And kind of taking a couple steps backwards to not only identify, all right, well, what's the root cause of what's going on? Whether, is this training error? Is it fueling? Is it nutritional? Sleep, stress, and all of the above is usually the answer. That's usually a big combination of all those different things.
Yeah.
And okay.
Cool. Yeah, no. I think we've already started to walk into the next thing I wanted to talk about, which is
Yeah.
like the examples of people. Like, what do you, besides targeting their, systems, health, and overall like preventative work there, and optimizing their lifestyle, like, do you treat those situations differently from like an orthobiologics perspective or shockwave,
Yeah.
or like, is
Yeah,
there an
sure.
obvious like direction you take from your clinic and your perspective and expertise?
Yeah, I think a couple examples there. So, the first would be like a younger in season athlete or someone who's training hard, has a kind of specific goal in mind, or is trying to get through, like, you got a event in 2 months and they're dealing with a chronic tendon injury or a nagging injury that's not getting better. At the same time, they are feeling like they need to maintain a training load in order to be able to optimize to get to a certain endpoint. I think that's a much different conversation than someone who's in their, mid 40s, 50s, who has, chronic aches and pains, but at the same time, they're not training for anything in particular. They're training for life, but could maybe take some time off and then rebuild and recover. So, I think the in-season athlete, we need to be a little bit more careful with our interventions as far as maintaining what they're doing from a training perspective. And that's, for biologics, I think that's probably not the best time to be exploring some of these biologic treatments because it does require some time off and as well as some protection of the tissue or the joint after the treatment. And then it really takes a while to ramp up and to improve. And so, usually
Good
I'm
to know.
treating those patients more with things like shockwave, where we can do that while they're in season. The downtime's pretty minimal. Sometimes things like Toradol or anti-inflammatory injections are a little bit safer alternative to doing steroid potentially that we can use to get them through their season. And then really working with a good PT, nutritionist, or their coach as far as, can we decrease load enough to the point to give this, problem a little bit of rest without compromising their training or their overall goals. And then when they're in their off season, then we, have them do some relative rest. We circle back on correcting whatever biomechanical or training issues they had going on. And maybe then that's the time we talk about biologic treatments if they're still not improving. And then I'm kind of on the flip side, for folks more like me, you've got a job and 2 kids and you're busy, but your life isn't. I'm not making a living by doing with sports, and don't have a whole lot of athletic goals anymore at this point, besides being kind of fit and healthy. Those folks, I tend to steer more towards biologics as an initial treatment as opposed to doing a steroid. And I think, especially keep coming back to knee OA because it's just such a common thing, but knee OA, gluteal tendons, things like that. We've got pretty compelling data that if we want to fix this problem long term, the biologic treatments like PRP are just a way better solution than putting a Band-Aid on it with a steroid. And so I try and tell people, like, I can get you better for 2 months with a steroid. There's a good chance you're going to be back. It might be worse. Maybe not, let's hope not. But at the same time, if we kind of invest in doing the right thing the first time around, I think we can get you better at 3 months and keep you better long term is really the goal. And then that's kind of an individual discussion based on what we're treating and what their goals are too. So recognizing where patients are and then what's the definition of success? Everyone's a little bit different. Does success for you look like, PRing a marathon, or does it look like walking up and down the stairs without your knee hurting or dancing at your grandkid's wedding and not
Yeah, sure.
having hip pain? So, just trying to dial in what that patient's goal is helps me really understand what I can do to help get them there.
Yeah, makes sense. Awesome. Rad. Well, what do you do to protect your joints?
So I, like many medical professionals, I have not taken my own advice for years and years. And I'm sure you're not
Right.
like this because you're
Clearly.
probably much smarter than I am. But at the same time, in the last couple years, I've started to notice like, oh man, my knees have been achy and sore, and they have been for a long time. And I think a lot of that was bad biomechanics and probably overtraining in the gym as far as continuing to do some movements with improper form that weren't serving me.
Mm-hmm.
So I really backed off on that. I actually got myself into physical therapy, which has been helpful. And then I've done PRP on my own knees a couple times now, which has actually really helped. The last treatment I did was about a year and a half ago, and my knees feel super good, along with doing some of these other things to modify the kind of training load I was putting across my joints. And so working more on the mobility, flexibility side of things, taking some more rest days, I think has been definitely helpful. Along with just kind of recognizing that, as you age, I think you need a little bit more time to recover sometimes, and that's okay. And then kind of embracing that. But I wish I had a magic bullet or like some pill that just fixes
Right?
it. Oh, yeah.
How
Usual,
do
same stuff.
you quantify recovery for your athletes or yourself? Like, I know what I do for my autoimmune patients that are
Yeah.
like super susceptible to feeling symptoms from that oxidative stress load and that kind
Hmm.
of chronic inflammatory load. I know kind of what works in my patient population, but it's pretty different than what you're doing. Are there metrics you're looking at? Are
Yeah.
there, algorithms you use? Like, what's the way you look at that?
Yeah, I mean, I think there's a lot of different ways to go about doing that, and it really depends on, I think, on the athlete and what their training goals are. So, someone who's a professional, semi-professional athlete, they're gonna have a very kind of regimented training plan with built-in rest days. And for them, tracking things like HRV, resting heart rate, I think those can be really useful to determine, when you're pushing up against that realm of overtraining and what that looks like. And those athletes can kind of, I feel like a lot of them can push themselves really hard through discomfort to a point where it can be, past being productive. Um,
Yeah, create injury.
right? Yeah. For the average kind of amateur athlete like myself, I tracked HRV and did some of that stuff for a long time. But I found over time, if I'm actually honest with myself and kind of listen to my body and decide, if I modify what I'm going to do for activity based on how I feel, that's a really good metric for me. And I also try and just build in 1 to 2 days a week of actually doing real rest, and I make sure that actually happens. So I found that to be just as effective on kind of a lower tech scale without doing as much biometric
Just the
tracking,
gut
which,
check.
so
Yeah.
yeah, for me, just wasn't as sustainable to keep doing kind of over time. I think I did that for a while and I got a lot of really good information and kind of got a good feel for what that
Yeah.
feels like. And now I can kind of modify that on my own.
I'm
I'm
using the
actually honest
same
with myself.
things with
Yeah.
people though, and I agree. I do typically the gut check for myself now and kind of know what I need, but I feel so often for people I hear that exercise is their stress release, right?
Yeah.
Like, what are you doing to relieve stress? I go running every day. I'm like, well, that's
Mhm.
great. Like, it's a stressor.
Yeah.
So it's great for that emotional release, but sometimes there's no like off gas valve for the oxidative stress at that point, right? The
Yeah.
actual physiologic stress. So for a lot of my patients, those metrics we're using very similar metrics and looking at those day to day and seeing patterns to kind of determine how many rest days. And typically, when
Mhm.
I follow those things for people, we're able to, like, increase that hormetic stress resiliency, like, more and more over time,
Mhm.
as they, like, allow that rest, right? Whereas they might come in with, like, their autoimmune is, like, raging, their inflammation's high, and even, like, going for a walk can kinda hurt, right? So we're starting with, like, yoga or whatever we're
Yeah.
starting with, right? And we're starting where they are, and then as we, like, pay attention to those biometrics and listen to those signals, and we're able to allow more and more stressors over time that their body can then
Mhm.
adapt to positively. So it sounds very similar to what you
Yeah.
do. I was just
Yeah.
curious since this is what you do.
Yeah, and I totally agree with you, and I think, um, modifying things in a way where, you're taking into account kind of that allostatic load, right? The overall stress of what
Yeah.
your life and your work and your exercise all combined, and then knowing your bucket can only hold so much of that stress, right? So something's gotta give at a certain point in balancing that. And then also, trying to have patients have hard and easy days, or even, for myself, like when you go hard, have a really hard day in the gym, but then feel okay with taking a rest day afterwards, instead of having this chronic kind of going 75, 80% where you're in this,
Right.
tempo every day is grinding away and you don't really go super hard, you don't go super easy. And I think that's where people run into that overtraining, fatigue,
Yeah.
and also
Yeah.
you're not gonna see performance benefits at that point too if you're just kind of beating yourself day in, day out, but you don't have easy days, you don't have hard days. It's just everything's kind of
For sure. I mean, especially if you're doing like these like boot camp climb up and it, well, I do have a little bit of a bone to pick with the like, mid zone, like marketing themselves as hit training boot
Yeah,
camp
yeah.
classes that are membership models. I think those are really tough, especially in the perimenopausal crowd because they're in that like zone 3, zone 4 work zone every single day. And like you said, they're not getting the high return on investment for performance or longevity benefits from that, but they are increasing their oxidative stress load without
Yeah.
recovery typically.
Yeah, and not
So,
recovering enough in between potentially, and yeah.
yeah.
Yeah, I'm with you.
Um, so I'm sure your athletes know this, but a lot of my patients don't know this, that recovery is more than just rest days. Like it's how are you sleeping? How are you feeling? What else is going on in that overall bucket of stress, like you mentioned. Um, cool. Well, I know we got to wrap up, but what else? Is there anything I missed? Is there anything you want the listeners to know? And then tell us a little bit about where people can find out more about you. Like, Mark does consults for our patients at Wild Health. So if you're a Wild Health patient and you're interested in any of this, and we haven't brought it up to you, first of all, sorry. Second of all, please let us know so we can send you to Mark and he can give you some advice. But he has his own practice that I'd love for him to tell us a little bit about in Bend. I think it's in Bend, right?
Yeah.
So let us know. And then if there's any other subjects that I butchered or missed and you want to let
No.
our listeners know about, then here's your time.
Yeah, no, that was great. I mean, I think to kind of wrap things up, I think the big things that I'd like to leave people with is just the recognition that in orthopedics, you should be thinking beyond just the joint, right? So we need to think a little bit broader than just the mechanical stress of the joint itself. And we've got a lot of tools there to help that or people that have these chronic joint pain, tendon pains that aren't healing, that don't necessarily need or want surgery, but also feel like they're kind of stuck with what they're doing. And so, your joints are metabolically active, and there's a lot of things like we just talked about that go into that. And part of that is working with, your primary or good doc to help optimize metabolic health. And then part of that's something a sports medicine doc can also help with. And so, yeah, I'm really excited about where we're headed in this field and the interventional orthopedics, orthobiologics. Every year we're getting more and more data and more things that we can do, and a more personalized approach to actually using your own biology to help fix some of these problems, which I think is a huge paradigm shift, and it's just a really neat field to be in right now. So, um, as far as the Wild Health patients, I love working with the Wild Health consults because I feel like you guys do such a good job on some of this other stuff we've talked about that it lets me kind of focus in on the orthopedic and sports medicine side of things, which is really cool. So happy to see patients do Wild Health. And then I've got a practice in Bend, Oregon. So I work at High Desert Sport and Spine. Our website is hdssbend.com. And then my personal website is goodmansportsmedicine.com. So reach out if questions come up, and yeah, hopefully I'll get to come back on sometime and talk more about this. It was super fun. Erin, thanks for having me.
Yeah, for sure. One more question I thought of as you were describing that. So people who aren't living in Bend, like one, do you consults with those people besides through us so you can give them direction on what to even look for? Because a lot of people have never heard of these things, I think. I could be misspeaking, but
Yeah,
I think even a lot of providers aren't super familiar with like what's really being done right now and what is the true Wild West and not yet available or appropriate, right? Like where is that line? So, what do people do if they have these situations and they're not in Bend, right?
sure.
Like,
Yeah.
what is this, like, common, or are you kind of a unicorn doing these
Yeah,
fields?
there's some good sports medicine providers out there, certainly. Most larger cities have some good primary care sports medicine docs or non-surgical sports medicine docs out there. So I'd look for someone who has done a sports medicine fellowship in your area and who also has training in ultrasound and orthobiologics. And there's more and more of those folks out there. Also do telehealth consults for people. I've
Do
a
you? Okay,
yeah,
rad.
I have people that fly in for these treatments, so I'll see
I
people
was
that'll come in
curious, I was
overnight.
gonna ask that
Yeah,
because I
it turned
imagine there's not, a ton of people that are super
yeah,
well vetted since this is a newer field.
yeah.
So yeah,
A
go to
lot of a
Bend,
lot of
it's
people want a
beautiful, go
reason
see
to
Mark.
come yeah, a lot of people want a reason to come to Bend anyway, so they come in and,
Yeah.
ride their mountain bike for a couple days, and then we do their biologic treatments, and they go
Sounds
home, and we
terrible.
follow up by telehealth. So we've got ways to do that too. So we can help
Cool.
facilitate that.
Sweet.
So
Well, yeah,
out.
reach out to Mark if you guys have any questions. Cool. It was good talking to you.
Yeah, thanks, Erin. I'll talk to you soon.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.